Hey everyone, it's me again, Sam Ashu. I just want to say thank you for being a listener. And before TR and I dive into this month's episode, I want to point your attention to EBmedicine.net. If you are taking the Lifelong Skills Assessment for 2024, that's the LLSA test for 2024, the study guide from EB Medicine has been released, and it is jam-packed with CME. That's a total of 26 CME credits you can get for completing that and taking the test. And some of it is in some specialty areas like pain management, pharmacology, addiction disorders, and even infectious disease. And if you're curious what kind of CME your specific state requires, there's even a tool for that at ebmedicine.net. Go to the map, click on your state, and it will show you all of your CME requirements and which ones can be furnished by EB Medicine. All there at your fingertips at ebmedicine.net. And now, let's jump into this month's episode. All right, everybody, welcome back. It is me, Sam Ashu, and my partner on the other side of the microphone,
Dr. T.R. Eckler, double trouble this week, back and ready to go.
We today are talking about two articles. We're going to spend the majority of the time in the Pediatric Emergency Medicine Practice article on substance use in adolescents, but we will be touching on the Emergency Medicine Practice article on headaches, because I think there are some salient points there as well. So let's dive right in. This is the October 2023 article, Pediatric Emergency Medicine, Substance Use in Adolescents, from the authors, Dr. Athale and Dr. Stoner. I don't know where you would be, honestly, if you haven't noticed this trend. There is an increasing trend of adolescent drug use across the nation, much like there is in adults and in the opioid epidemic. But in adolescents, it's certainly not limited to just opioids. There are a variety of drugs of abuse which are being used in this population. And unfortunately, adolescent substance use accounts now for 2 to 3% of annual ED visits. That's as of 2017. So that's the most recent data that we have here in the introduction of the article. And that includes everything from marijuana, methamphetamines, MDMA, stimulant drugs, cocaine, all of the opioids, and alcohol, as well as tobacco in these surveys as well. So tobacco products are included when we talk about adolescents and substance abuse. And it is something that is increasing with alarming frequency, and unfortunately comes with a not insignificant number of deaths. 7.5% of all the unintentional overdose deaths in 2020 occurred in people aged less than 25. And the largest proportion of them involved opioids and stimulant drugs. So it is certainly a crisis in the country. And if you're in the emergency department, this is not news to you. So this particular article was devoted to the discussion of all of the different drugs that we encounter, what some of those clinical presentations look like, and then also some of the limitations of the diagnostics that we use in the ED.
Yeah, having been the rural places on both coasts of America, I find that it doesn't really matter where you are. This stuff just keeps getting more accessible for adolescents. And I think especially post-COVID, as the mental health crisis continues to worsen for adolescents with rising rates of anxiety and depression, this is going to get worse. And it's our job to continue to signal how bad this problem is and to be ready to keep an open mind as to exactly what kind of chemicals and substances people can be getting into, especially young people.
Yeah, and frequently their presentation to the emergency department is either some kind of intoxication or altered mentation or new bizarre behavior being picked up by family or friends, or it can be complete obtundation, so some kind of mental status change, or it can be something more psychiatric, a change in personality, suicidal ideation. It can come with psychiatric illness or be the first presenting sign of psychiatric illness in some adolescent who hasn't disclosed this to parents or close friends. So it's a mixed bag of presentations, but certainly the most dramatic is the altered mental status, the person who's confused, combative, agitated, or apneic, unresponsive, and severely intoxicated. Speaking of mental health, the 2020 Substance Abuse and Mental Health Services Administration, that's SAMHSA, study showed that adolescents who had a major depressive episode in the previous year were more likely to use illicit drugs or alcohol and nicotine products compared to adolescents without a major depressive episode. So just more evidence that there's a close tie and that some of those presentations in the emergency department can be mixed, not just substance use related, but mental health as well.
Yeah, I think my biggest takeaway from this paper was just you've got to keep a curious mind about these cases when you've got a kid that's intoxicated or might have overdosed on something, and you've got to try to get as many information sources as you can, whether that's your partners in mental health, paramedics, family, teachers, whoever you can get information from. There is someone that will give you that kind of golden thing that tells you what it is that they got into, and just cast a broad net. This is a young person with a lot of quality years ahead of them, and the more you can do to bail them out of this situation, the more, of an impact it's going to make going forward.
Yeah, absolutely. We talked today about this in adolescence, but if you live in a town with a university or a college, then you see this in that age population all the time as well. And some of this survey data includes people up to 20 years of age. So we're also talking about the new to college, freshmen, sophomores, that age group as well. When it comes to emergency care, we talk about our pre-hospital colleagues and what they typically see and what they contribute to emergency care. In this population, it is, as always, a significant amount that they are seeing. They're called to the scene for somebody who's altered or acting abnormally. Certainly, if the person is apneic, then history there isn't something you can obtain from the patient, but you might be able to get it from family, from friends, from looking around the scene and seeing drug paraphernalia, and then giving a trial of naloxone or Narcan. And if you are working in the pre-hospital setting, you're already very familiar with this. Narcan can be administered intranasally, intramuscularly, intravenously, whatever method you can get it in the system.
I strongly prefer nebulized treatments because I find it wakes people up gently, and I spend less time arguing with them about who exactly woke them up.
Yeah, it's interesting. The article doesn't mention nebulized Narcan for its timing of onset or its duration of effect, but why not? I mean, we nebulize a bunch of other drugs, and do you think it has a more gentle onset of action as opposed to the rapid reversal you get with intravenous dosing?
I would tell you that when we're talking about the pre-hospital setting, I think it's very important to give that first dose as fast as you can when you're trying to bring someone back if they're not breathing enough, if they're hypoxic. But if you have someone that's now in the emergency room that's getting more somnolent, that's getting more hypoxic as their dose is wearing off, you've got more of that time to say, okay, I think this is an opiate. They had responded to Narcan, but now it's wearing off. So now I'm worried that it's a more long-acting opiate. I think that's a good time for the nebulized Narcan, because as opposed to then fully waking the patient up again and having to discuss with them the fact that they need to stay, you need to monitor more, you just put 2 milligrams of Narcan and 3 cc's of saline, run it like a normal nebulizer treatment over maybe 10, 15, 20 minutes, and they gently wake up. And then they'll realize that the medicine's waking them up, and they self-titrate. And all you need to do is keep an oxygen sensor on them, and then you can see when they've taken it off. It's really nice because there's times where people will be on a Narcan drip and they'll rip their IV out. And trying to get IV access on someone that's a difficult IV access can be a real problem. This is a nice thing to bridge that situation and make it so you don't have multiple emergencies piling up on you for these people.
Yeah, that's all excellent advice. Now, if you're in the pre-hospital setting, like you mentioned already, you've got multiple methods of delivery, and Narcan is now, even, at least in our state, it's free and available. In multiple states, it's free and available. And typically over the counter, it's either intranasal or injectable intramuscularly. The intranasal pumps are becoming very popular. So that dose is 4 or 8 milligrams and is administered in the nose. Intramuscularly, it's a dose of 0.4 or 0.8 milligrams, and then repeated every 2 to 3 minutes. And again, our EMS colleagues are very accustomed to doing that. The most important salient details come from family and friends and what else is at the scene. And certainly there are other complications. Now we're talking about the person who's apneic. They certainly can be unresponsive. They can be hypotensive. They could be pulseless, and you may have to start CPR. So the scale of critical care that's needed to treat people in this setting is really quite variable depending on their presentation. They also can be confused and combative and altered. And so there's a good discussion here about not forgetting the basics, things like checking a blood glucose, making sure they're not hypoglycemic, not just because there could be something else going on, but also because that can occur from the drug use. and obtaining ECGs, being aware that you might encounter seizures, being aware that the person who's confused in front of you might be post-ictal because they had a seizure from the substance. And so lots and lots of things to keep in mind in the pre-hospital setting as you're trying to get this person to the emergency department. And if you encounter seizures, then you're going down that whole pathway for treatment with benzodiazepines that can be given, again, intranasally, intramuscularly, intravenously, whatever access that you have in order to stop the seizure. Interestingly, the authors of the article made note on this 2014 Cochrane review that said that IM midazolam was more effective than IV lorazepam for seizure cessation in the pre-hospital setting. You don't have to have the IV access if you can't get the IV access. IM meds work very well. And benzodiazepines are really the first-line agents for people with agitation who are thought to be using drugs, even in the adolescent population. Many of our EMS colleagues carry ketamine and use that for acute agitation. And the evidence for that in adolescents is not as good as it is in the adult population, but that's certainly an option. Benzodiazepines work very well, but if you are accustomed or have that in your protocol for ketamine use, that's certainly okay. There was actually a 2022 retrospective chart review of pre-hospital ketamine use in children and adolescents by EMS, described here by the authors in the article, used for treatment of agitation in behavioral emergencies. So not specific to just substance use, but all in general behavioral emergencies. And they had a very low number of adverse events. 1.8% had some kind of transient desaturation. 2.2% required positive pressure ventilation. And these are pretty small numbers. And it was a retrospective chart review, but at least it's something in this age population that says that it's okay and acceptable to use ketamine, just like you would in an adult.
I like, especially in these overdoses and these ingestions where you're not always sure what you're dealing with, I always like to start with midazolam Versed because it's the short-acting thing that I can use, and it's probably going to make things not worse, and it at least buys you some time to think or get the patient stably transported to the hospital. And I think then adding ketamine onto that is something that if you can't get control, then I'm good with that. But I don't like to lead with ketamine here because I always think having some benzo there for some seizure control is something that's going to be safer and it's going to help you out in those cases where you need it.
Yeah. It does complicate matters a little bit. If they're acutely agitated, I never blame my EMS colleagues for using ketamine. But if there's a way to finagle your way out of having to use the ketamine, you just have to watch them longer. They come in significantly altered, and then now you're wondering, okay, how much of this was ketamine? How much of it isn't ketamine? I don't really have any baseline for what they were like before they got the ketamine because I wasn't there to see it. And so it can certainly complicate matters when you're dealing with somebody who's altered and maybe even lead to more testing and diagnostics than is necessary. But again, I don't ever blame my colleagues for using it because it's a whole different thing in the back of an EMS truck or even at the scene when you're trying to get somebody in the truck to get them to the hospital. And so you do what you have to do to keep yourself and the patient safe.
Yeah, but choosing between that and Ativan or Haldol, the amount of time that I get to when I think the medicine's out of their system, and like you said, like now I know what their kind of level of alteredness is without that drug, is a lot faster.
And then, of course, when they get to the emergency department, you're going to perform your normal history and physical. The history is going to be limited. Maybe there's family around. The physical, you're looking for things that might give you a clue as to what substance you're dealing with. Are their pupils dilated? Do they have nystagmus? What's their cardiopulmonary status? Are they tachycardic? Are they hypertensive? Are they tachypnic? Do they have bowel sounds? Is there any belly pain? What's their neurological exam like? Maybe looking at their skin. Are they sweating? Are they flushed and red? Some of those things can clue you in. Needle track marks, those kinds of can suggest what the etiology might be. And then we're moving on to diagnostic testing. Now, when you're doing the exam, there's actually an excellent table in the appendix of this article pulled from Up to Date that talks about the toxidrome presentations from multiple substances. That's Appendix 1, Common Poisoning Syndromes. And it goes through sympathomimetics, anticholinergics, hallucinogenics, and what the mental status might be, what the vital signs would be, what the skin and pupil and other physical manifestations would be. And that's great. It's great to read. It's great to have. It's a wonderful resource. It's in the interactive pathway. It'll be there in the mobile app. But it's also important to remember that sometimes it's a mixed ingestion, and you're not going to fall nicely into one category. So the most important thing is to treat the patient for what you're seeing in front of you. And along those lines, you're going to get some testing done. And this is going to be, again, pretty routine in most emergency departments. You're looking at glucose level, so it's probably been checked pre-hospital. You're going to check it again. You're going to get basic electrolytes because hyponatremia can occur with multiple substances. And in the setting of drug use, especially if you're talking about MDMA and those kinds of drug and free water intake, and there's lots of reasons why their sodium might be low. Liver function tests, a CBC. If you think they have cocaine ingestion or they have any kind of chest discomfort, the article talks about troponin. There's a mention of testing for co-ingestions, salicylates, Tylenol levels, alcohol level, always testing for pregnancy, and then blood gas analysis if it's helpful in guiding you in their respiratory status. Creatinine kinase, if there's a worry about rhabdo, if they were down for a prolonged period of time, if they were using some kind of stimulant, if they had any kind of restraints, either physical at the scene by law enforcement, or if they had to be strapped down onto the gurney and were fighting most of the way, agitated, tachycardic, and hypertensive, you can certainly get rhabdo in those kinds of scenarios. And then the all-important drug assay. We get urine on all of our patients. We try, and we test for the presence of these substances. But this urine drug screen is so unreliable. It's silly that we still get it. You get a lot of false positives from all kinds of over-the-counter substances, and you get a ton of false negatives because so many of the drugs that are available now are either synthetic or analogs of other drugs of abuse that don't pop up positive in the typical urine drug screen. So we're still doing it, but there is gas chromatography, which is far better in detection of substances and definitely not available to us in the emergency department. So no one's getting gas chromatography and mass spectrometry to try and detect substances in their blood unless it's some kind of legal case and they're drawing a legal blood draw for something. Otherwise, we don't really have access to that in the ED. And so we get the urine drug assay. Most of the time, it's looking for the typical contributors, things like opiates and amphetamines. Sometimes it's oxycodone. If you're lucky enough to have one of the newer ones, you can detect fentanyl specifically. But those are the kinds of things that are not going to pop up the synthetics. So a synthetic opioid like fentanyl and even like oxycodone would not show up as morphine positive in your drug screen. And if you have use of things like spice or synthetic marijuana, that's not going to show up either in your drug screen. So lots and lots of substances are not going to pop positive. And there is a little bit of cross-reactivity there. They might be prescribed amphetamines for attention deficit disorder, right? So that'll pop positive as well on their drug screen. And so it's there. We do it anyway, but not necessarily as helpful. It's all about treating the clinical syndrome.
I find it confuses me as often as it gives me confirmation of my diagnostic suspicion. But I tend to use it more as a tool with the patient as a stepping stone. As I'm still trying to figure out the history, I say, boy, there was this in your drug screen. Are we worried that they were being poisoned? Are they worried that someone would have tried to give them something? And I'll bring that up in like a non-threatening way that then the patient or the family is a little more is a little less feeling attacked or feeling like they're in trouble. And they're more likely to say, oh, we thought he was getting into this. Or we have some of this. Dad has back pain and has some of these pills and they went missing. It's possible that he got into that. There's two things I would add to this. Actually, I take it back. There's three things I'm feeling additive today. One, I feel like you need to get an EKG in these patients because I always want to know right off the bat, where am I starting with their QRS? Where am I starting with their QTC? And kind of what does their rate and their rhythm actually look like? Because if you have a Benadryl overdose, if you've got an overdose of nausea medicines or antipsychotic medicines, the only way you're really going to be able to see a sense of that is what their EKG looks like. So I think that's an important tool when you're talking about their diagnostic studies. I always like to keep lithium in the back of my head because I feel like it's an easy thing to miss, but you're talking about a patient population that is more likely to have mental health problems, is more likely to have some diagnosis of bipolar and might be on lithium. And then the last thing I would add, I really like to know end-tidal CO2 if I can get it from EMS, but if the patient comes in and I'm putting them on the monitor and I'm worried about their ventilation, I'm going to try and get that end-tidal CO2 started early because it's something where you can walk by the room, see where their oxygen's at, see where their end-tidal is, and it gives you a much better idea than just the oxygen alone of how well you're doing and if their respiratory status is changing on you under your feet.
Yeah, I absolutely agree with that. The end-tidal CO2 is very helpful, is going to pick up on poor ventilation far sooner than your pulse oximetry, and it's non-invasive. And most of the time they come in with it on already from EMS. And so it's an exceptionally helpful tool. Yeah, lithium's an interesting one. I don't see as much of it prescribed anymore, but certainly other family members may even have it. So if there's a sense for a possible suicide attempt or something they may have taken, that would be something you definitely want to learn early. And yeah, totally agree about the ECG. If that wasn't done already in the pre-hospital setting, certainly repeating that. And when you call poison control, which we all recommend you do, that you engage them early, they really do offer a lot of information, and most of the time are just reinforcing what you already know, that this person needs observation and nothing more than just supportive care. But the ECG is something they will always remind us of. Did you do one? Would you get one? Tell us what their QRS is, because it's just one more tool to pick up on a possible other substance that they ingested.
I would tell you most of the time, in my experience, I'm calling poison control after I've essentially got the patient there, done a good exam, gotten the best history I can, got an EKG, got a glucose, and maybe some sort of ISTAT labs if I want them. But I'm not waiting for most of my other labs to come back before I engage poison control. Because if there's anything that I feel like I'm missing, because this is something that they do every day, I want to involve them as quickly as I can, especially in this young adolescent patient, to just make sure that if there's a chance I can catch something early, I'm on it.
Yeah, I agree. And they're accustomed to being called multiple times. They'll follow up with you on a case, and it's okay to say, hey, I don't have the labs back yet. And they'll call back when they are. Or sometimes they'll ask you to call them when the labs come back so that they can continue working down their algorithm. So absolutely, engage them as early as you want. In fact, in some cases, they already know the patient's on the way because some family member called and they called 911 and were directed into poison control that way. Or EMS called and said, hey, we're bringing in a bunch of pill bottles. So sometimes they already have information on a case that's helpful before they've even hit the emergency department. There are a couple of good tables on page 6. One is drugs of abuse not commonly included on a urine drug screen, so ketamine being one of them. LSD, we mentioned synthetic cannabinoids, synthetic opioids, so that's buprenorphine, fentanyl, methadone, and tramadol. None of those show up on the standard drug screen. Oxycodone itself, unless you've got one that's specifically testing for it, will not show up. MDMA, ecstasy, Molly, all those amphetamines and benzodiazepines, most of your typical urine drug screens are not going to pick up on those. And then table 2 lists common substances that are going to cross-react. So this is giving you a false positive drug screen, which can sometimes give you a little anchoring early and inappropriately. So you might get a positive amphetamine screen because they've been on Sudafed. Or some antihistamines like Benadryl will trigger positive amphetamines. Beta blockers, fluoxetine, carbidopa, levodopa, selgiline, all of these things are going to trigger positive for most urine drug assays for amphetamines. Opioids, a little less frequently, but things like fluoroquinolones, like Levaquin and Cipro will give you positive opioid screens. Poppy seed ingestions, Benadryl again, quetiapine and verapamil, and then if you're testing for marijuana, hemp-containing food products, there are a number of things that will cross-react. So it's a good table to have in your back pocket, especially for the person who absolutely swears they didn't take anything. These things are exceptionally inaccurate, and that you can't certainly call a patient a liar.
Yeah,
just
not a good time to stand on your lab and say, I know the truth. This is not that time.
Yeah, this is not the one.
This is not your a few good men moment here. This is not it.
The alcohol level, maybe, but the drug screen, no, that wouldn't do it.
That one I feel more comfortable thumping my Bible a little bit and being like, hey.
And then some things to keep in mind. So when we talk about treatment principles, like we mentioned earlier, just treat the patient for what they're presenting with. If you can't figure out what they took, it's okay. Most of it is supportive care anyway. There was a significant discussion in the article about each specific kind of substance and some specific things you might want to know regarding that, starting with marijuana, which of course is increasing in popularity and I'm sure legalized in most of the states for the listeners that we have here in the U.S. And interestingly, the potency has gone up. The amount of THC in these drugs, or if they're synthetic, increased affinity it has for the receptors is causing the drugs to be more potent. And so instead of just the lethargy and somnolence you might get, we're seeing more and more things like agitation and seizures. And if we get into the synthetic cannabinoids, things like acute onset of psychosis and hallucinations and some serious derangements in mental status, which you don't traditionally associate with marijuana. So if they're using things like spice and K2, you get a whole different set of side effects and symptoms than you would from just what you would associate with traditional marijuana.
Yeah. The numbers they threw out in the article of basically the average concentration of 3% in 1995 for THC products versus 14% in 2019. It echoed my experience in Colorado, which was just things just kept getting stronger and more concentrated. And because of that, people were having more side effects. And it reassured my approach to tell people that, if you can try to cut down or cut back or use things that are not as strong, I think that that's going to be a much safer move for you.
Yeah, and with that increase in potency comes increasing side effects, which include the cannabinoid hyperemesis syndrome. And I don't know about you, in the last 10 years, this has become exceptionally routine in the emergency department. The number of people we see and treat for this is on a daily basis is increasing. Sometimes they will admit it. Most of the patients still are in denial about the fact that it's their marijuana use that's contributing to this. And they're going down that whole, well, I've seen a GI, I've seen 2 GIs, I've had 1,000 scopes and multiple scans, and no one can figure out what's wrong with me. And then eventually you get down to, there's only one thing left, and that's your consistent daily use of marijuana, which has increased in the last few years. Interestingly, the ultimate treatment for this syndrome is cessation of use of marijuana. Unfortunately, you got to stop for at least a month, but sometimes you've got to stop for 6 months before you start to notice a difference. And that's a really long time to ask somebody to run a trial, especially if they're used to using marijuana on a daily basis. But that's what I tell people. Hey, you've got to stop, and you've got to stop for 6 months before you're really going to notice something. And that's what it's going to take. And then after that, it's a lifelong cessation. So not like you're going to go back to it in 6 months. You're just done.
I find that this is something that, like you said, you've got to approach it just by talking through the patient and kind of explaining to them that everything else doesn't seem like it's really what it is. So maybe this could be. I tend to give patients a couple different antiemetics. And if that's not working for their really ugly nausea and vomiting, then I'll try basically some IM Haldol, because it almost always makes them feel so much better. And then I think they're much more open to that conversation of, look, this is about the only thing that is really going to respond this well to it. You can also see whether or not they're really responding to hot showers at home. Hot showers and hot baths are really pretty pathognomonic for being one of the things that relieves cannabis hyperemesis. I would tell you that there are some people that I've given them the capsaicin cream, which I felt like I was being a little bit of a cruel doctor, but the relief they get is dramatic. So I think having that also in your back pocket is pretty important. I think they mentioned giving lower doses of IV Haldol. I always found that the safety of giving IM Haldol, either 2.5 or 5 milligrams is more reliable. And I think it's going to give them a more long-acting relief from their symptoms.
Yeah, I personally do. If they have an IV in place, I don't mind giving it to them IV. They're usually on a monitor at that point anyway in the emergency department, and we've gone through 1 or 2 drugs and it's not working. So if they're not on a monitor, I'll just slap them on one and we'll give it to them IV. I think those dopamine drugs work exceptionally well for this kind of disease. Now we have droperidol available as well in emergency departments. It's making a comeback. That was previously taken away for the black box warning. So all those people are going to get that ECG and get slapped on a monitor anyway. So if you're going to give it, this is a good population to do it in. There is a role for benzodiazepines in this particular disease entity as well. So a milligram of lorazepam IV every 6 to 8 hours can also result in some sustained relief. And then, like you said, there's a 92% correlation between hyperemesis and the hot showers. And so if they have that historical finding, that's actually been studied in a systematic review by Sorensen et al. That was the one quote in the article, said this was seen in 92% of patients. So if they have it, it's very, very likely that this is the disease process they're dealing with. And then it just opens up the door to have that discussion. So these patients can sometimes escalate in therapy. The more times they come in, the higher doses you have to give them each time. It's helpful to know their history. So if you know that, hey, the last time you were here, we went through 4 antiemetics and nothing worked except for the Haldol, we're just going to jump straight to the Haldol. That's totally okay. I've even had patients tell me, hey, I don't want the Haldol. I had too many of these weird side effects afterwards. And we'll kind of talk them through that and say, oh, we know none of the other things work and it's just Haldol that's going to work. So if you want anything, that's what I'm going to give you. But I'm happy to treat you so that we don't get those other side effects, and talk about Benadryl and antihistamines for home use, that kind of thing. Alcohol was another big category, and certainly we're not unaccustomed to seeing this. There's a couple of interesting points that they brought up in the article that I thought were worth sharing. First is that in the unhabituated adolescent, as they would call it, someone who's not a chronic drinker, even a serum level of 50 can be intoxicating. And then severe intoxication is, around 200 in somebody in this population. And we're used to seeing those chronic alcoholics, they're walking around at 300, they're intoxicated at 450, and they might hit a high of 600 in some cases. But those are really the chronic drinkers in adolescence. If they're registering between 50 and 100, that's definitely indicative of levels that can result in intoxication. Another interesting point was the possibility of a alcohol-soaked tampon being a relevant factor in this case. So,
have you ever seen that?
I have never seen that, actually.
I had one. And it's a scary thing because if you're not looking for it, like their alcohol levels can go up. It's one of the reasons I try to repeat an alcohol level, because if their alcohol levels are still going up and you're a little concerned, it's a good thing to have in the back of your mind as to be looking out for.
Yeah, I thought that was a great point. And sometimes these people are so intoxicated, you're going after urine with a catheter. And so you can tell your nursing colleagues, hey, while you're there, you're doing a cath UA. If you happen to see a tampon, then let me know. We'll do a quick exam. You can be the chaperone and I'll do the exam and I'll remove this thing because this may be a factor in this case. And sometimes just sharing that with nursing colleagues can be what ends up alerting you to the fact that this is present. So I thought that was an point.
It can be vaginal or can be rectal. Both are, you got to be on the lookout for.
Yeah, that would be even worse. They did mention that there was a small study of 100 patients, pediatric patients, who got admitted to the ICU for alcohol toxicity, and 57% of them required intubation. But I do think it's important to remember that these are pediatric patients getting admitted to an intensive care unit. Most of our alcohol intoxicated patients get observed and go home. So very rarely are we admitting someone to the intensive care unit that's an exceptionally sick population. I'm not surprised to see that 57% required intubation, because I would expect them to be that sick if they're needing to be admitted to the ICU for alcohol.
Was that ethyl alcohol or was that toxic alcohols?
This was just alcohol toxicity. It didn't specify which one, but that does bring up the good point that when we talk about alcohol, there's ethylene glycol, there's isopropyl alcohol, there's methanol. So it's not just ethanol that we're accustomed to seeing. There are multiple other ways of becoming alcohol intoxicated. Interestingly enough, another thing we don't think about in this population is alcohol withdrawal, but it certainly can occur if you're seeing someone in this age range who drinks regularly, and then now the parents are finally discovering it. They've been found out they don't have access to it like they used to. For whatever reason, they can come in with alcohol withdrawal, and that's something to keep in mind. First-time alcohol withdrawal can be perceived to be something like acute drug intoxication. They're hypertensive and they're tachycardic and they're not acting right. And maybe they're vomiting everywhere. They're unable to keep anything down. The parent's concerned, what's going on? They were drinking before. We took away all that. Now I'm wondering if they're on drugs. And you go, well, actually, we're dealing with acute alcohol withdrawal because 2 days ago you took away all their access. So something to keep in mind. And then there's the stimulant medications. So when they're presenting, if you're worried about things like methamphetamines or MDMA or cocaine, this is the category of patient we talk about who is coming in agitated, tachycardic and hypertensive and altered, and sometimes maybe even hyperthermic. So the methamphetamines can certainly cause hyperthermia. If you're dealing with somebody who's so agitated that none of your benzodiazepines are working and you're having to go after things like cooling measures, then there's actually an entire different article, Pediatric Emergency Medicine Practice in 2017, that talks about how to deal with heat-related illness and cooling measures. But there was a little bit of discussion of that here in this article, how to cool someone who's hyperthermic. More importantly, if you're going to have to paralyze them and intubate them, then you got to keep in mind that this is somebody you want to use a non-depolarizing agent in and avoid succinylcholine, because that same stimulant drug disorder can cause them to have rhabdo and hyperkalemia and acute kidney injury, and all of those things cause an environment that is not friendly to the use of succinylcholine. So something important to keep in mind. And then cocaine, the relevant factors there, again, we see it all the time, but if they are having chest pain, an ECG is helpful. A troponin is helpful. They're still able to get myocardial injury, even if it's not plaque rupture related. They're still at higher risk, especially if they're regular users.
The only thing I would go back to is just the serotonin syndrome. I always try to keep this in mind with anybody that's a little agitated, a little erythematous, tachycardic, anyone that can be in that sympathomimetic overdose kind of picture. I think I always want to have some benzo there and kind of make sure I have a good sense of what medicines they're on, because especially if they're on an SSRI or an SNRI and some of the other drugs that can predispose them to this, I want to have a sense of that early. Maybe that's because I'm from New York and I remember like the whole Libby Zion era, but I think that it's something that if you're not watching out for and always having in the back of your mind, it's going to try to sneak by you because it's hard to always catch.
Yeah, I've seen that a handful of times in tramadol as well. People who are even regular users taking too much or have a one-time overuse. But it is another important point to bring up that MDMA does have that cross-reactivity with serotonin receptors as well. So those people are going to be at higher risk for serotonin syndrome, which presents slightly differently with muscle tremors and rigidity and agitation, in addition to the tachycardia and hypertension, maybe without the classic history of having abused things like meth or cocaine. So definitely something to keep in mind. And if they're on, as you mentioned, any kind of serotonergic drugs to start with, they're at higher risk for this, but they don't have to be. It can be just a pure presentation the first time. Opioids, obviously, there is the epidemic that's going on across the country. If you are accustomed to seeing this in adults, you will recognize this in an adolescent. The deaths from opioids have certainly increased in this age population as they have in adults, and opioids are one of the leading causes of death from drug overdose in the United States right now. Fentanyl has certainly contributed and continues to be a problem in all communities across the nation. And again, it doesn't show up on the standard urine drug screen. Some places have an additional test you can add. You can inquire about that with your lab for fentanyl. The most important point here being is that in the acute treatment, you need to make sure you have naloxone available. Also, if they're dealing with any of the other synthetic opioids like methadone, then that is something that's going to require repeat dosing. And there's a discussion here in the article about dosing, both intranasal, IM, IV, and frequency of dosing and how to set up an infusion, all of which are very, very helpful when you're dealing with somebody who has a large opioid overdose. If you haven't read up on this already, the problem with fentanyl and other synthetic opioids is their increased affinity for the mu receptor. Fentanyl specifically is about 100 times more potent than morphine, but there are some other synthetics out there like carfentanil, which we're starting to see in communities across the U.S. for some time now, that can be up to 10,000 times more potent than morphine. And so it's important to know that very, very small doses of these substances contaminate all kinds of drugs, and people may be thinking that they're buying one thing and getting something completely different, or they may be buying an opioid that's been contaminated or intentionally had this substance added to it to try and increase the euphoric effects. But since it's not being titrated in a lab somewhere by a pharmacist, you don't really know what you're getting. And they may be purchasing or taking their normal routine amount and then having sudden catastrophic accidents and accidental overdoses, which just brings up, again, the importance of naloxone and its availability at home and to the general public. And one of the reasons why it's started to become available in pharmacies all across the country without a prescription. You just have to go ask for it. And in most states for free as well. I know in our emergency department, we've got it available and we hand it out to people, even with legitimate prescriptions, but certainly in these kinds of cases, when they're going home, we will get them to go home with.
I think I feel most comfortable just handing it to them because I think there's a stigma of trying to fill a prescription to it. And I think if you just hand it to them, that makes the biggest difference because now they've already got it and they're not worried about going to get it. And what does that mean?
Yep, absolutely. Absolutely. There is a good discussion in the article as well about opioid withdrawal and when might be an appropriate time to start something like buprenorphine for someone who has a problem. Nowadays, most of us are going to be renewing our DEA license soon anyway, and we're mandated to take the course, but the courses do an exceptionally good job of talking about this and when it's okay to start these kinds of programs. And you can certainly begin that in the emergency department and set them up with outpatient follow-up. And just because they're an adolescent doesn't mean that you can't. Just like you would in the adult population, this population is ripe for this kind of medication-assisted treatment, and it's still highly recommended even in the adolescent age.
Anybody that comes in with an overdose for me or anybody that comes in asking for help with treatment, I offer them buprenorphine now, especially in the age where we don't have to have a special license to prescribe it, because I think if I give it to 10 patients, I'll probably help one of them get clean.
Yeah, it is a life-saving therapy, and the more we use it, the better. And then lastly, just screening for suicide. So in all of these ingestions or accidental overdoses, it's important at some point to have a discussion when the person has resolved their alteration in mental status about suicide, making sure that they're safe at home, making sure they're not being abused at home or they're not somehow being trafficked, and making sure that they have a safe place to go. if there's a parent or guardian there, having that same discussion with them, because often they're leaving the emergency department and you're giving them the follow-up. You don't really know if they're going. If you can engage a parent or guardian, that helps, but making sure you're screening the patient for suicidality is critically important.
I would just add two things to that. One, just as I was looking at this, I went back and looked at some of the numbers for opiate deaths in America. We lose 150 people a day to opiate deaths. So I think that this is the biggest thing that concerns me. And I also think it's worth noting that I think now the majority of party drugs, if tested, contain fentanyl and dangerous levels of fentanyl. So I think even if someone says that they took a pill and it was this or and it was that, and that's what someone told them it was, I think you really need to assume that there's going to have to be some risk of opiate in there, and just always keep your mind open to that there's a lot of contamination, even in things where the pills can look exactly like other pharmaceutical pills, but they're not, they're contraband. And it's just, again, this is just an area to stay curious and always keep asking if you really have a sense of all the things that are going on in this picture.
Yeah, it's a critical conversation to have, especially with the patient. Whether an adolescent or an adult, you're educating them to the fact that they just trust that what they're buying off the street is Xanax or oxycodone, but they really have no idea what's in the substance. And so it can be eye-opening to test them for it and say, look, you had cocaine in your system, which you admit you were taking, but you also had fentanyl. And let's talk about that, because this is life-threatening. The next time you go to use the normal amount that you think you can take, you're going to die, and that no one's going to be around to resuscitate you. And that can be eye-opening for people. Or, hey, you took some Xanax, or your best friend told you this was a Xanax tablet. Turned out it was fentanyl. And that's very, very common. And so it's a great reason to have this conversation with patients and say, you're not buying this at a pharmacy, you're picking it up off the street, and everything on the street is contaminated. Yeah, another excellent point. So kudos to the authors, Dr. Athale and Dr. Stoner. It's an excellent article. There is so much more in here talking about each one of these substances, timing of onset, how it's used, reversal agents. It's just a jam-packed article, of course, as usual, and available here at ebmedicine.net or in your mobile app. I highly encourage you to go read it and then take the CME test and get your 4 hours credit for looking through this article and getting your education on substance abuse. The biggest take-home point being that it's very prevalent in adolescents, and it is something we see commonly in the emergency department. It is commonly encountered with co-ingestants, and there are lots of things that go along with it, like what substances they've taken. Are they suicidal? Is there a history of mental health? Do they have a safe place to go when they leave? In addition to just the routine medical care, which I think in this case, honestly, can sometimes be the simplest part of it. So many things to keep in mind. That kudos to them for writing such an outstanding article. We also this month want to touch on the other article in emergency medicine practice on headaches. Now, this one, again in October, published by 4 authors, Dr. Penjwani, Dr. Saini, Dr. Winkle, and Dr. Friedman, was a review of emergency department management of migraines and other primary headaches. So not talking about the differential diagnosis and recognition of things like subarachnoid hemorrhage, but really just what do we have at our disposal to treat people with chronic migraines, which is another one of those frequent emergency department visits, nearly 5 million a year now, encountered in the ED. So if you're working in the ED, surely you've seen patients with chronic migraines, and you've had this discussion about here's what we have available. And sometimes you give them those medications and they don't work, and you start to wonder, okay, what else do I have at my disposal? And I thought these authors did a really good job of reviewing current medications, but also then in setting up a pathway that you can follow for what medication to use and then how to escalate that therapy to try and help the patient who has a migraine that just isn't going away.
I thought this was a great article. I came here to be awarded and validated for my use of IV Decadron for migraines over the years, because I feel as though that has been questioned by neurologists and other older physicians that I've worked with at times. So I'm very excited for my merit badge that steroids have finally come into vogue, and they do prevent these bounce back migraines. So I really love to give these people Decadron either early or later on when I'm really starting to tune them up. And then I love putting Reglan into the bag of IV fluids. I think making it not that you're pushing it, but you're giving it slow. You really then probably don't need to give them that IV Benadryl, and I think that makes a huge improvement. And I find that sub-Q Imitrex, really, sumatriptan sub-Q is really effective and really is a nice, second or third line for me when I've given them everything else. The only thing I would add is that I find that IV magnesium has also been a pretty big help for me and does a lot for these patients. And I felt like they didn't quite touch on that in here, but I think the rest of it, I'm excited for the future of migraine and headache treatment because I feel like there's new interesting drugs that are happening. And I still haven't quite gotten to the point where I'm starting to prescribe topiramate or beta blockers for my migraine patients going home. But I think as that date gets better, I might get there.
Yeah, absolutely. The pathway that's in here begins with just one question is, are they suffering from a cluster headache? Because you can use high flow oxygen for that, or maybe a sumatriptan, and then just send them home without having to do any IV therapy at all. But if that's not what they're suffering with, then the algorithm goes down metoclopramide, dexamethasone as first-line agents, and then repeating metoclopramide, maybe adding ketorolac in there. And then if that doesn't work, going to things like dihydroergotamine. And then there is a discussion about some of the newer agents, these anti-CGRP medications, which are probably not available to you in the emergency department anyway. But I thought it was an interesting discussion because these are probably coming down the pipeline. Some of them are available orally and are single dose. There are newer serotonergic medications that are also available orally and available single dose that are coming down the pipeline. And then they did a really good job of discussing nerve blocks. So if it's not your common practice for people with occipital headaches, you can actually do greater occipital nerve blocks. There's even a discussion of a sphenopalatine ganglion block, which involves just taking a syringe with a few cc's of bupivacaine and dripping it with an angiocatheter into the back of their nose while they're laying flat to try and give them a sphenopalatine block. There's no needles involved. There's no sharps. You could perform this in just a matter of minutes and honestly make a significant difference in somebody who is suffering from a headache that hasn't been amenable to other therapies. There's some great pictures on page 11 on how to perform both of those blocks, and an excellent discussion on the pathway that they built and why they chose those medications. They also did a good job of discussing pregnancy-induced headaches and some of the medications that are approved in pregnancy, and that's kind of why they ordered the pathway that way. In fact, metoclopramide and dexamethasone are perfectly safe in pregnancy, and that's your first line right there. And then, as you mentioned, there is the discussion of oral medications as prophylaxis. So propranolol, metoprolol, valproate, topiramate, amitriptyline, all of these can be used for prophylaxis of migraines, and you don't necessarily even have to prescribe it. You could just mention it to the patient and say, go see your primary or your neurologist. All of them have side effects. All of them need monitoring of some sort, but still, if you're living in a life of pain and you have frequent headaches, this can be life-changing for you. And I thought they did an excellent job of reviewing that, but especially of building a pathway that becomes very transparent and easy to use in the ED for, here's my first line, here's my second line, here's my third line. I'm just going to keep going down this list until we get to headache-free. One of the important things that I thought they brought up that I will say was a deficit in my own education was this concept of medication overuse headaches. So this isn't actually something I've ever read anything about or had ever talked to anyone about. The authors discuss in people who have chronic headaches or severe migraines that they can use an excessive amount of medication and that they can have what is termed medication overuse headaches. They note that it's quite common and often under-recognized and affecting up to 5% of the general population, and that there isn't a specific quantity of medication that would put someone into this category, but prolonged use of analgesics, triptans, other headache medications all can lead to changes in pain processing. And this can result in medication overuse headaches, and that this is something you might talk to the patient about. There's a good discussion of it in the article. Treatment is interesting because treatment can either be go follow up with your neurologist and have this discussion to see if you fit into this category, or you need to be admitted to the hospital for withdrawal of these medications to see if we can resolve your medication overuse headache. And honestly, in this day and era, when emergency departments are filled, we have not enough room for anyone. The hospital is constantly on backlogs, and admitted patients are just sitting around waiting in the emergency department boarding. It seems hard to think about admitting someone for status migraine or medication overuse headache for withdrawal of medication. But it's an important thing to keep in mind. I did not even know this was an entity. And so I encourage you to go grab the article and sit down and read it and just add this to your armamentarium of something you can even just discuss with the patient. A lot of times people who have chronic migraines don't want to be in the hospital. It's loud. They keep you up all night. They're constantly interrupting you. There's not a chance to go get into a quite dark room and try and resolve your migraine after medication's administered. So most of the people I encounter don't want to be in the hospital. They want their medication and they want to go home. But it's an interesting entity, and I thought it was worthwhile mentioning.
Great read, great pathway. Again, it's just something that's going to reinforce good practices and make me a little better.
Awesome. And that's it. So 2 great articles for the month of October: Pediatric Emergency Medicine Practice and Emergency Medicine Practice, Substance Abuse in Adolescents and the ED Treatment of Migraines. Go read both. That's 8 hours of CME right there for the month of October in 2 outstanding articles. And if you're not a subscriber, ebmedicine.net, or you can go take the CME test in the mobile app. And if you're not a subscriber, you can get that app for free and peruse the articles that are available. And those pathways will be in that mobile app very soon. And that's it for the month of October. Thanks, TR. I appreciate you being on the other side of this microphone.
Great to be here. Can't wait for next month.
And that's a wrap for this month, everyone. Thank you again for joining us. Don't forget about ebmedicine.net. And if you're taking that LLSA 2024 examination, go get the study guide and claim your 26 hours of CME credit. And while you're there, take a look at the CME map and make sure you've got everything you need before you recertify your state license. And of course, the mobile app, the interactive pathways, the special courses, all of those extra goodies, all at your fingertips on your mobile device or at ebmedicine.net. Until next time, be safe, everyone.